So right now we have done 3 cases. Each case, I think we have learned quite a bit in terms of how to wire and how to manage these patients acutely. The last patient we did not have the valve all the way across when we were doing the cutting, and the patient actually developed torrential MR and had some initial instability, but we were then able to get the valve across and then deploy, and that patient did fine. It is a bit of a complex technique, but I think the point of this presentation was to show that, well, sometimes that choice of repair versus replacement can be quite difficult for any patient. I think all of us on this panel are involved with repair as well as replacement therapies. And having that discussion and getting patients into the replacement arms can be challenging because repair is so easy and so good. But unfortunately, most repair techniques right now completely close the door to replacement. And this is an idea of showing what may be possible in the future, that maybe the choice doesn't have to be so hard.
Hey, Paul, I know it's obviously you're releasing it from the anterior and pinning the mitral clip posterior. Have you done follow-up CTs? Do you have any concern that there's going to be any erosion? I suspect it's not much movement, but have you seen anything? How are you following these patients? Is there any concern about erosion from that clip device being pressed against the posterior wall? Yeah. Or is it not pressed? I'm just curious how it looks, how it sits.
It's slightly pressed, but not pressed very tightly. And I think as far as the erosion goes, we haven't seen it. I think partly because there's little movement on the posterior side, plus the myocardium is relatively thick there. I think we tend to think of erosions with like the ASD occluders, which can hug the aorta or left atrium, where the myocardium is very thin. But in this area, it's pretty thick and pretty immobile. For one of the patients, there was actually an anterior SLDA with the clip. And that one, I did have some concerns that eventually it could embolize. But it turns out that that patient had this clip in for 4 years. And I think it's pretty well healed in, and it hasn't shown much movement in the follow-up we've done.
Paul, for these patients, do you think they need to have long-term anticoagulation, as the mitral clip is relatively voluminous in the left ventricular outflow tract or in the left ventricular cavity?
Yeah, great question. So for the Tendyne TMVR, like I believe Intrepid as well, it's 6 months of anticoagulation as a minimum. In follow-up, I think it's probably a good idea to be on Coumadin long-term. We haven't really settled on the correct antithrombotic strategy for that. But you can imagine, I think you're right, Alan, you raised a really good point. These clips, these tissue materials are sitting in recesses. They are sitting in trabeculi that can be prone to thrombus, and it's a really good consideration. Honestly, you raise a point that I need to think about a little bit more.
And it doesn't distort the valve at all, like the Tendyne?
No, the frame of the TMVR device expands very well. I think all of these devices, even whether they're all self-expanding in their current design, they're pretty rigid, and they essentially push the leaflets with the clips on out of the way.
I think the other advantage of both the devices is we have an outer frame and inner frame, so the functioning part is always circular.
Yeah.
Paul, my question was, so technically, can you always predict whether you're going to cut the anterior part or posterior, or it just happens as it happens?
So there is steerability on the guide catheters, because when you unflex, you can go anterior, or counterclock, you can go anterior. But sometimes when you create the loop, you're absolutely right. You can end up above or below the clip, and it can be very difficult to undo that loop and push it forward, per se, to get it to go in the direction you want. Our goal is always to go to the anterior side, because we want the clip to fall posterior and stay out of the LVOT. But in terms of the control, there's some, but it's not optimal.
I think this just brings a very important point. And Sushil, if you remember, we always used to say there are some patients who are mitral clip for sure, some patients who are surgical for sure, but there are some in between. And these are the patients where you actually want to try mitral clip. And if it works, it's perfect. If it doesn't, then we should have surgical option or this. Now, this patient, as I saw it, had multiple, it was a re-op as well. So I think attempting a mitral clip before was justifiable. And if you don't, it's a borderline case. And if it doesn't work, then the next bridge in this particular patient could be TMVR. And if not that, because of LVOT issue or sizing, then it could be reoperation. So I think that's probably the way this field is going to shape.
I mean, question for you all. I mean, you all are enrolling in these TMVR studies. Are you struggling with these discussions in some patients, choosing repair versus enrolling in a study to replace the whole valve?
I can, oh, go ahead, sorry, Molly.
No, go ahead. I was going to say, absolutely. We sit there and we try to guess who we think would be, best for each technology. But if you think about it, that's biasing all the studies anyway with the different types of patients that we can put in. Put these devices in. So, yeah, I mean, it's a constant problem, I think.
Sushila?
Yeah, similar. And I think some of the issues are the leaflet thrombosis issues, anticoagulation. Now, a lot of the MitraClip patients are in AFib, but it's different level and consideration for anticoagulation. And also, CLIP has a very strong data set, and even not just the patients they're referring. So like, well, you start saying, well, I'm going to consider for a trial. We get the CT scan, let's see what the LVOT, and go back and forth. And they're like, why don't you just do the CLIP? But the reality is, I think there's still those patients that Vinny said, and that are not really CLIP candidates, or they're borderline CLIP candidates, right? They have thickened leaflets. You're going to lose a lot of valve area. You're going to end up with a valve area of 1.8. The person has a BSA of 1.8. It's not great. And so, I think in those type of patients, it's where there are ones where you would not try MitraClip, but those type of patients where you say, well, maybe I'll be okay if I put a single clip, I get ERO down to 15 or something, and they're doing okay. But if not, or the gradient goes up, and I can do this, what you did, and do a replacement. I think there's advantages to not doing a replacement up front. So I think there's a lot of those patients, like Vinny talked about, that right in that gray zone, right? Clear CLIP candidates, clear not CLIP. But I think for that big pot in the middle, I think these are interesting options and discussions.
Yeah, and in addition, there are the CLIP patients who you thought were great CLIP candidates, but they ended up not being great because of some technical issue that happens that surprises us and humbles us all the time, right? Alan, what do you think?
Yeah, I think we see a fair amount of patients who have that very dilated LV or that decrease in LV function that unfortunately the leaflets are so pulled apart that they're not going to be a good MitraClip candidate. However, doing the transapical puncture also is not going to help them over the long run. So those are the patients that we struggle dramatically to try to treat. But there's been a couple of options where, as you guys said, that you hope to have a great clip, a great result with the clip, and then end up with a suboptimal one. And this is actually a good technique to potentially treat them a different way.